the advocacy in Texas and talking to us a bit about that. When I think about what is it that patients really care about, what sort of changes do patients want to see, who's the voice for HIV patients, January is one of the forefront for that population in Texas. So thank you, January. Thanks for coming.
Thank you, Michael. And I'm going to try to clip this on here so I'm not awkwardly holding it in my hands. All right. Tell me if you can't hear me. I tend to speak louder, but if you need me to speak louder, then just let me know. Like Michael said, my name is Januari Leo, and I work with Legacy Community Health. Is anybody here familiar with Legacy? Okay, Dr. Kaiser is. Legacy is a federally qualified healthcare center. We have 22 plus clinics in Houston, Beaumont, and Baytown. We also have clinics in all of the KIPP charter schools as well. What that means as an FQHC is that we don't turn anybody away who walks through our doors. So we see everybody. If you can't afford, we take private insurance, Medicaid, Medicare, all those good things, but if you walk in and you don't have a payer source, we're going to figure out how to take care of you. So it's a great thing. Legacy has its roots in the HIV STD community. So we got started in the mid-'80s, back when the HIV crisis, really AIDS crisis at that point, looked very different than it does now. So, you know, there wasn't a lot of information out there. And because of that, there were a lot of doctors, a lot of nurses, a lot of practitioners who didn't want to have anything to do with people because there wasn't enough information. You didn't know if you were safe or if you weren't safe. So what the folks at Legacy did, it was then Montrose Clinic, is you got a group of doctors, nurses, community activists who came together to provide a space for people living with HIV. It started out doing testing, evolved into treatment, and in 2005, Legacy became a federally qualified healthcare center, or FQHC, as you might hear me call it from here on out. So now we do pediatrics, we do primary care, we do behavioral health, vision, dental, health and nutrition. We do just about anything that you can think about, but our roots are still very much in the HIV and STD and LGBT communities. And that's why we make such an investment, a policy investment, in making sure that we cover these things. What I do at Legacy is I'm the Director of Public Affairs, so I look at healthcare policy and figure out if we need to have a seat at the table, you know, if we need to do some organizing around it, you know, making sure that the policy looks good up here, because if the policy doesn't look good up here, by the time it reaches here and on the ground and you're implementing it, it can be a real mess. And then you have to go back and correct it, and that's a big process. So those are some of the things that we're going to talk about today. I know I've got an online audience as well, so hello, online audience. I like to take questions as I'm going along. So I have a PowerPoint, and the way I think that I'm going to do it is so that our online folks can listen as well, or give feedback as well, is kind of after each slide, I'll stop and I'll ask if you have any questions, and we can discuss, and then we'll move on to the other one. Does that sound okay? Perfect. Okay, so, oh, I'm guessing this is my clicker. Oh, there you go, that's me. How many folks here have a background in HIV, STD care? Mostly we're going to be talking about HIV today, not really STDs. Okay, so a few people. So just to give you a few brief statistics for what it looks like in Harris, I know we're in Galveston, but the area that I cover is largely Harris County, and Harris County is overwhelmingly affected by HIV. You know, you look at the number of new cases in 2013. Data tends to lag, so we don't have all the new good data as of yet. We're slowly getting that. So 2013 is the last that we have. Overwhelmingly male. It's not up here, but overwhelmingly African American as well. So we've really seen a shift in who is affected by HIV. Let's see, Houston ranks 12th in the United States for the number of new incidences. And I say new incidences because I try to be careful about my language that I use. I work with somebody who's HIV positive, and she's really been trying to teach me about language and how it's important, the words that we use. So I don't like to say infection, because infection sounds like infection. I say incidences. So you'll hear me say that a lot. If I don't, then you can correct me. So Houston is ranked 12th in the number of new incidences in the United States. Harris County has the highest number of new diagnoses in Texas. And Texas ranks 10th in the United States for new incidences as well. So Houston, we have a problem. It's something that we see a lot here in Texas. A few things that go along with that, and we're going to talk about that briefly, is Texas has the highest uninsured rate in the United States as well. So you add things like high uninsured rates, you add poverty, you add lack of access to any number of things, and those things just compound the issue of HIV in Texas, in Houston, in whatever jurisdiction that you're talking about. And the South has really become the epicenter of the epidemic. I didn't put a slide on here. I should have. I can get it to you. When you look at a map of the United States and it shows you where the new incidences are or where, cases are of HIV, from Florida, this little chunk here, Florida, the South, it's blood red, because the South, the cases have really moved from what we traditionally think about in New York and California. They've moved down here to the South, and that's because we have a lot of broken systems that keep people from getting care, from learning about education. We're going to talk about all of these things today, some of these policies that are in place that are problematic, and also some policies that we could pass that are good as well. Any questions about this? Online folks, any questions? All righty. Okay. When you came in, you should have gotten a sheet, and this tells you about a plan that Legacy is working on this year, and this is an end of HIV plan, and we're doing it for the city of Houston specifically. When we got the grant to do this, we thought, okay, do we do this statewide? Is this something that we should look at? And what the point of an end of HIV plan is to bring down the number of new incidences over a set period of time. And we thought about it and we said, Texas, if we're looking at Texas is number one, it's huge. And so to maneuver all those different moving pieces, you've got urban, you've got rural, you've got some really different things that are going on. And second, politically, getting things done in Texas right now is very difficult and different when you're talking about issues that we are typically fighting for. And so we said, okay, well, how about we just do it for Houston? Houston is the largest city in the state of Texas. We've got a very progressive congressional and state and city council delegation. And so if we can get them on board with some of these changes that we're going to recommend, then that's something that we can use as a model for the rest of Texas. So we said, okay, we're going to focus on Houston. So what we are doing with this grant is we have brought as many people to the table as we possibly can. This started out with a big conference that we did on September 8th, at the end of March. And we did a 2-day conference. The first day was really a data dump. So we were telling people, the state of at a national, a state, and a local level, talking about intersections, because you can't talk about HIV without talking about race, and without talking about religion, and without talking about LGBT issues, without talking about domestic violence. So we wanted to bring all of these people to the table because we tend to operate in silos when we're thinking about HIV. And in order for us to really begin and get serious about bringing down new incidences of HIV in Houston and in Texas and in the United States, we all have to start working together and be on the same page and be communicating with each other. So that's what we did. We got as many people to the table as we possibly could. We had about 100 people there. It was by invitation only, so we tried to be very specific in who we invited and who, with their experience, the things that they had to offer to give that. And on the second day, people divided up into work groups. And those work groups are, they are access to care, prevention, social determinants of health, criminal justice, and policy and research. And each of those work groups has met once a month from April through, this is their last month that they'll be meeting. And they meet once a month for 1 to 2 hours. And they're charged with coming up with a set of recommendations specific to that category. And then those recommendations, we'll take those. We'll all come back together on September 8th, which is coming up soon. And we will look at those as a group and see if there's any tweaks or additions that need to be made. And then we'll take those and we'll make final recommendations. The final recommendations will then be presented to Mayor Turner of Houston. And because we really want his sign-on and the city's sign-on, while, you know, it's not exclusively up to them to implement this, it's going to be across systems. You know, the political piece of it gives it some weight and gives it some validation. And so that's what our hope is. We actually set this up last year during the mayoral race, when I'm constantly in some kind of race. The mayoral race, when, you know, we had 5 or 6 different candidates. And so we did a mayoral forum where focused on healthcare with a couple of different agencies. And our question was, if we brought to you an end of HIV plan, would you sign on to it? And we've got him on the record saying, yes, I would. So that's something that I can take to him now and say, I've got you back here saying this. We've got this great plan. We really want you to be on board with helping us make this happen for all Houstonians. So we will reveal our plan on World AIDS Day, which is December 1st of this year. And then the hard part begins, which is the implementation and you know, making sure that this actually happens. So I will make sure that I get invitations out to Michael. He can forward them on to all of you, because we would love to have everybody, anybody who wants to come, anybody who would like a set of recommendations there, so that you can see what our thoughts are on that. So that is our end of HIV plan for Houston. Any questions on that? Y'all are a quiet group. Y'all gotta ask me some questions. Okay, now we're gonna get into the policy piece. And what I focused on for this presentation is statewide policy, because that's really, you know, as a state, it affects all of us. So I've picked a few things. Obviously, we don't go into session until January of next year. And so Texas has session every other year. They meet from January to the end of May. They have 140 days to get everything done that they have to get done. They have one thing that they have to do, only one bill that they have to pass, and that's the budget. So if the budget doesn't get passed, we've got a problem. They'll go into special session to try to get it done. But thousands and thousands of bills are filed every year or every other year, and they've got to get through as many of them as they can. Some are going to take precedence over the others, and that's really where, you know, us as individuals, as advocates come in, because we really need to be the ones driving the conversation and saying, this is a priority, this is something that needs to happen. Here's my experience, here's the experience of my clients. You know, if we want to see change, we've got to have this kind of change. So that is what session is coming up. So we're going to talk about a couple of those things today. The first is the elephant in the room, Medicaid expansion. How many people are familiar with Medicaid expansion, or have just heard the term Medicaid expansion floating around over the past 5 years? Yes, if you're in medical profession, generally you will have. So as you may or may not know, and I'll go ahead and I'll explain it a little bit, Medicaid, each state sets up their own Medicaid parameters. And Medicaid in Texas looks like you have to be disabled, fully disabled, a child, or a pregnant mother. Those are the folks that are eligible for Medicaid in Texas. So that really makes that a relatively small pot of folks. Kids take up a massive chunk of that, and that's the Children's Health Program, which is doing really well and has a lot of kids that are getting covered on the Children's Health Program. What Medicaid expansion does is it eliminates the disability piece of everything that I just said. So all they're going to be looking at is pretty much your income. So your income is going to determine whether or not you're eligible for Medicaid in Texas. This is something that came out of the Affordable Care Act. This was when they did the Supreme Court ruling in 2011. This was what we didn't expect. So they upheld the individual mandate. They upheld, Affordable Care Act overall, but they said what it had originally said was states have to expand Medicaid, otherwise you're going to lose all your Medicaid funding. And the courts came back and said, you can't do that. That's not really fair. So they gave states the option of whether or not to expand Medicaid. So what has Texas done? Opted not to expand Medicaid. So this would have, the first time this could have gone into effect would have been January of 2014. If we had started then, over a 10-year period, we would get $100 billion, with a B, billion dollars. So every year that we don't expand Medicaid, we're throwing that money away. We're sending it away to, Kentucky's kind of on the fence now. Let's say Louisiana, New York, California, Massachusetts, all these other states who are saying, yeah, send us your money, we'll take it, we'll take care of our folks. And so there's a lot more conversation to be had about that, but it's really been a fight in the legislature over the past 2 years, 2 sessions, I should say, 4 years, on whether or not to expand Medicaid, because there's lots of different ways that you can do it. The federal government has given us, some flexibility to make it look like we want it to look. We call it the Texas solution. A lot of times you'll hear that floating around, because if you go into some lawmaker's office and you say Medicaid expansion, it shuts down conversation immediately. So, kind of thinking of that language and how we talk about it. I put this up here with the X through it because even though session doesn't begin until January of next year, if you ask any healthcare lobbyist or healthcare advocate or anybody who's on the ground and in the know about Medicaid expansion, they'll tell you there's a 90% chance that this isn't going to happen this session either. And that's simply because we're looking at the makeup of the legislature, who's invested in it, who's not invested in it, and it's just not a friendly environment for Medicaid expansion right now. Does that mean we stop talking about it? No, not at all. We always have to keep telling our stories. We always have to keep talking about why this is so important. And this is particularly important for people living with HIV because we did a study with Harvard Health Law and Policy back in 2010 that looked at how many people living with HIV would be eligible for Medicaid if we expanded Medicaid, and it was about 76% that would be eligible. If you're familiar with the Ryan White system of care now, which is really the system that comes in and takes care of a lot of people living with HIV, it's a payer of last resort. So only if you have no other form of payment will Ryan White step in and take care of those costs. So, and they only take care of so many things. So they're taking care of your HIV issues, whether that's case management or your medical care, prescriptions, things like that. That's what Ryan White takes care of. Medicaid takes care of a whole lot more than that. So it's looking at more of a whole healthcare system. We had a case at Legacy, and this is not a joke. So when we started doing marketplace enrollment on marketplace plans, we got a man, an older man, who we got him enrolled in the marketplace. So he had full insurance. He had been on Ryan White for 10 plus years before that. 2 weeks later, he got hit by a bus. And you always hear that about, people get hit by a bus. But he really did. He got hit by a bus. And Ryan White wouldn't have taken care of that. So what would that man have done if he didn't have some form of insurance? He would have been stuck with a very expensive insurance bill. But now he had some ways to be able to take care of that. He got to go to the hospital and get taken care of, and it was a little bit less worry off of him for that insurance piece of things. So the beauty of healthcare and healthcare coverage. I understand there's a lot of complicated pieces to that and a lot of discussions that we could have, but that's kind of the quick and dirty simple of it. Any questions on Medicaid expansion and where we're going with that? Okay. We're getting some more specific bills here. So one bill that we are going to be talking about and really pushing during the next legislative session has to do with syringe exchange. And this has been going through, we've been trying to push this for, oh man, almost probably 20 years at this point. We have syringe access in Texas, but we do not have syringe exchange. So, Walgreens, CVS, they can sell bulk needles and things like that. That's what we're talking about when we talk about access. But syringe exchange, what syringe exchange programs do is they allow people to set up, it could be legacy, it could be a separate entity that does it all by themselves. They set up somewhere where people can go and they can exchange their dirty needles for clean ones. Because what we've seen with really focusing on syringe exchange programs and with needles is that there's very little cases of HIV through syringe anymore, and that's because we've done a lot of work on education and making that happen. So this is just another step in that. The reason this is so important is because you're seeing a big trend of opioid abuse throughout the country. And there was a case in Indiana last year where the governor had to declare a state of emergency because they had this tiny little rural town in Indiana that had like 150 new HIV cases within a year's period of time. When we're talking about a very small rural town, we're a very small population, that's huge. And so we're starting to see this issue come back up again with syringe exchange and the need for syringe exchange programs. There's a lot of stigma that's attached to syringe exchange programs because what do you think of when you think of syringes? IV drugs. Exactly, just like I just said, IV drugs. But we have to think bigger than that because there's a lot, people use, they use syringes for steroids, which is still a drug, but it's a legal drug. So steroids, they use it to tattoo. So a lot of the communities we see, they use, they'll share needles to do tattooing. You'll see it with, we want to be able to protect our doctors and our nurses and our first responders for, if there's less needles on the ground or, in the areas that they're dealing with, then there's, a better chance that we're protecting the general public overall. And so syringe exchange programs are important. They're a good public health tool because we have to think about it from a public health perspective. We have to take morality out of it. And so this is something that we'll be looking at. It got further last session than it ever has. It actually got voted out of the House, which I was shocked. So that's a good sign that this has some movement. If we can do some education on this and really push this, I think that there is a good chance for us to finally see this happen. What this would do is it would make syringe exchange, it would set up a pilot program. So it doesn't completely make it legal across the state. It sets up a pilot program so they can begin to research and get some data on how these programs work. There's no money attached to it. You're not asking the state to pay for syringes, anything like that. It's just saying you can do it, and that's it. So that's syringe. That's a good question. Dr. Kaiser, do you know kind of their thoughts on it? I stay pretty close with some of the drug folks, and they haven't ever expressed any concern over this. So I don't think that this is something that they would probably weigh in on too heavily. It's slightly out of their wheelhouse, but if you bring the opioid piece into it, then that's different too. Mm-hmm. Yep. Mm-hmm. That's a good point. And we always work closely with them anyway when we're planning all of this out and when we're advocating. And I've yet to come across anything where they're like, we're not getting involved in that. Usually we're pretty much on the same page.
So why is this such a dilemma with Texas when the research in like Texas and all those places do have that exchange as well? Why are we like that?
Sometimes research only is a piece, it isn't even the most important piece in things. Like I said, there's a lot of it's the stigma of it, and it's well, we don't want to support drug users, and we don't want to make it easier for them to use drugs, and so we have to get them thinking outside of here and thinking out here. So, for most of the things I'm going to show you today, for all the things I'm going to show you today, we've got tons of research and things that back up our argument about why these are good public health issues, but sometimes politics outweighs public health. And that's just the bottom line of it, unfortunately. But the more people who come together and stand up and speak out and share their stories and their experiences, that gives more gravity to what we're doing and pushing for. Opt-out testing. This is another one. There's actually Department of State. So what opt-out testing is it makes HIV testing standard. So if you go in for your monthly well women check and you're getting blood drawn and they're checking your cholesterol and they're checking, your sugars and they're checking all the different things that you're probably getting an STD test, which doesn't include an HIV test. All of those things, HIV test would be thrown in there as well. And so it's just a standard part of the test that you're getting. You have the option to opt out of that if you do not want an HIV test. What this does is it eliminates a big piece of the stigma off of HIV, because a lot of times what we see is when people go in, doctors or practitioners, they won't ask somebody, do you want an HIV test? Because, I'm doing a judgment call on a person. I'm going, you're not at risk, which I hate the term at risk, because if you're having sex, you're at risk. Okay. You don't know what your partner's doing, period. So it takes off a lot of that stigma, less of a judgment call that the doctor has to make. And that's what this bill would do. This hasn't gotten anywhere in a while. So there actually is a group of people, Department of State Health Services has a Test Texas coalition. So they've got folks that are kind of doing pilots across the state who are trying to gather data and get more research on opt-out testing, what that looks like, what the issues are that they're running into, how that's bringing, if and how it's bringing down new incidences. In Houston, Memorial Hermann's emergency room does this, and the Harris Health, which is the county system, does this as well. So this is something that we'd really like to see be implemented across the board. Once again, as with everything, there's counter arguments to this. One of the things is the stigma that's involved with it. Sometimes doctors don't know how to deliver, you've got someone who's positive. Now I've got to tell them that you have HIV. What do I do from here? That's not something that I'm comfortable doing. Or do I know the resources to refer them? If I'm not somebody who can give this care, can I refer them elsewhere? Do I know where that is that I need to refer them to? So there's a lot of different things that that go along with this. When I met with the Texas Medical Association, which is the big, kind of group that advocates for doctors and the healthcare profession in Texas, they weren't as pumped about this one. They're like, yeah, we'll support it, but we'd rather see syringe exchange over this time around, because they feel like there's a little bit more argument to be made for that. This is a big one. And there's other states that are doing this with a lot of success. So this is something that we will continue to talk about. This is also something that, we can go and, smaller systems can begin to implement this without it having to be a legislative fix. So, if Legacy, which we have done it before and we're not doing it now, wanted to do this, that's an internal policy change. So there's lots of different levels of policy, and some of this is internal and some of it is larger than that. Any questions on opt-outs?
So if physician tries to do this, I think the problem is not that it's really easy to do. It's the fact that the resource to educate that. So wouldn't it be easier to do something like how we do TV policy rather than let the state take it over? Would that be a lot them to digest and put them in the middle?
So you're saying the state gives the diagnosis?
Yes. Figure out the physician's
That's one option. That's one option. Yeah, because usually if you're doing an HIV test in the doctor's office, you're not getting, there are places you can go to get your result literally within 2 minutes, a minute, I think it's down to now. But if you want to do a more thorough test, then it's going to take a couple of weeks to get that back completely. So yeah, so those are the kinds of things and suggestions that we're looking for when we're crafting policy, because we're in the process of putting these things together right now. The person who sponsored this in the past was Rodney Ellis. And Rodney Ellis, if you've been following all the political drama, is now county commissioner for Harris County. And so now his Senate seat is open, and they are actually on Saturday going to be, the precinct chairs will be choosing who his replacement will be. And so there's a lot of it's very up in the air right now, which is why we haven't found a sponsor for this as of yet.
That's always a shocker. So when you give them something like that, and they go get a normal, well-woman routine, and you give them the opt-out when they happen, that's usually when they find out like that. And so to take away would be really, I think.
And they do mandatory testing when you're pregnant. When you're pregnant, you have to have an HIV test. That is law, but otherwise you're correct. And I've got multiple stories because I work with a lot of folks who are positive and advocacy folks of women who were like, I've been going in for years and getting a well woman test, and I asked for an STD test, but come to find out, the HIV test is not included in that group of tests. And so they were getting sick and couldn't figure out what it was until they finally go and have the HIV test. And these are, like you said, heterosexual women. We're seeing a really growing population with our elderly because they are getting back into the dating game. They may be divorced. They may be widows. And they haven't been sexually active for, a long time. And so number one, they don't think they're at risk. Number two, may not have the education about condoms and some of these preventative measures that you can use. So the elderly and young kids are really two populations that we're seeing, because this group doesn't think they're at risk, and this group is it's not even on their radar at all, and they don't have the frame of reference that folks my age who, grew up watching people die all around you on a weekly basis have. So, yeah. Another, what I like to say is we've got all the tools to really bring down new incidences of HIV. You got PrEP now, you got testing, you've got all the education and the research, you've got everything. How do we put that all together so that it starts to make a difference? Because we're not seeing that right now. We're really not, if I'm being honest. Okay, HIV criminalization. This is a tricky one. Texas does not have a criminalization law on the books as of right now. So what that is if I'm HIV positive, I do not have to disclose to my partner before we have sex. So that's how it is in Texas right now. There's other ways that they get around these, and that's how we start to see people living with HIV become criminalized and for their status. And we saw this for the first time in a long time last session, and this was a really big fight and a very sensitive fight, because some of the times the things that we see happen, you're like, oh yeah, throw every book in the world that you can at them. But if you're looking at it like that, you're really there's about 76,000 people in Texas who are living with HIV. You're putting all 76,000 of those people at risk for criminal prosecution because they're HIV positive. So we really feel like it's something that needs to be taken on a case-by-case basis. You need to look at the intent that's involved. Was there an intention to do that? Or, at what point does personal responsibility come in as well? Because it takes two to tango. Not just one person is having sex. There's another person. You have a responsibility to protect yourself as well. So a very sensitive subject. This is one, what this would have done is it would have allowed HIV test results to be used in court proceedings. And so they're taking your HIV status and they're using it as evidence of the purported crime that you've committed that may or may not have had anything to do with sex or HIV. So very broad language. We have to be very careful when we're crafting policy about the language we use, because this can have a really big effect on a lot of people. We have to be very, very careful with it. So we just felt like the bill, it wasn't where it needed to be. It would have had, like I said in the beginning, if it doesn't look right up here, by the time it gets down here, it's a big old mess. That's a perfect example of it right here. So this got very far. This made it out of the Senate. It made it out of the House. No, it didn't make it out of the House. It made it out of the Senate. It made it out of the House committee. It made it out of calendars, but it literally, like last day, last hour, didn't make it onto the House floor. So we were very grateful for that. Hoping not to see anything like that this again next session, but we're prepared for it if it does. This is a tricky one, and there's a lot of discussion around it, and a lot of passionate people on both sides of it as well. Any questions about this one? Okay, this is always a big one. Comprehensive sexual education. In Texas, we go on an abstinence, a preferred abstinence model. So each school district really is in charge of what they want their curriculum to look like, but the state really prefers you to do abstinence first, if at all possible. That's really, if we're talking about HIV prevention, then it needs to start in the schools and with what kids are learning. Because like I said earlier, we're really seeing a rise among our young folks because they're not getting the information. It's just basic information that they need in order to keep themselves safe. I have two kids. My daughter is 14 and my son is almost 12. My daughter, and we live in Fort Bend, and in Fort Bend they go through health class in 7th grade. So my daughter went through health class, and she came home to me one day. She's like, "Mom, I need to interview you for some questions for my health class." I was like, "Okay, let's talk about it." And the things that she said to me that her teacher was telling her, this is teacher's coach, okay? Coach is telling her. I was like, oh, she's the reason I still have a job, okay? I was floored. They told her that condoms don't work 85% of the time. And just everything that she told me, I was furious. And these are the kinds of things that kids are learning in schools. I have another friend who her son's going to be a senior this year, but when he went through, him and his friends, they heard that if you drink Diet Dr. Pepper, that it kills your sperm count. And so that is their method of contraception. Diet Dr. Pepper, drink lots of it. You won't get the girl pregnant. These are kinds of things that our kids are learning either from school or from their peers. And it's really important that they be getting correct information. So it's a public health matter so that they can keep themselves safe, so that everybody around you is safe. And it seems like common sense, but there's a lot of pushback. Every year this doesn't go anywhere. And any time a school board tries to step in and really, make some changes to their sex education, they get a lot of pushback from parents. So this is a hard one in Texas. As you're seeing, it's hard to be an advocate on certain things in Texas. But we keep going on. Any questions on this? Okay, so that's the policy piece of things. I want to tell y'all a little bit about a program that we've been doing for the past 2 years at Legacy that I'm really proud of. This started out as a grant-funded program, and it's been so successful that we've incorporated it into our regular budget. So this is going to happen no matter what at this point. So this is our positive organizing project. And what this does is it trains people living with HIV to be advocates. And it's a 6-week program designed by and for people living with HIV. So you have to be positive to be in the program. There's usually between 15 and 20 people who go through the class at a time, and for the most part, all the people who are coming to do the trainings are people who are living with HIV, because there's something called the Denver Principles that we really believe in, and it's the concept of nothing about us without us. So, we don't ever want to speak at people. We want people to be involved in the conversation. So this has been a fantastic program. Dr. Kaiser, you may have been familiar. I think they came to one of the Medication Advisory Committee meetings one time. Big group of them, had lots of questions that they asked, and y'all were very generous and let them ask the questions and give them good answers. So really trying to get them to be advocates on lots of different levels, whether that's at a political level, whether it's for their own health care, whether, it's in the community amongst each other, really using their voices and speaking up and speaking out about this. So let's see, what else did I put? So yeah, just a few more things. They meet once a week for 6 weeks, and then they have they do a community project at the end that may or may not be HIV related. They do one HIV and one non-HIV community project. They do a big graduation, and then they do meet once a month to watch a movie or have a discussion or do something like that as well. Then the graduates become the mentors for the next class. So it kind of keeps it going and keeps everybody active and engaged. We are trying to be really mindful of barriers that people might have. So we provide dinner. We also give reimbursement for mileage and childcare, because we don't want people to not be able to participate because they can't find a babysitter, or because they can't afford gas money, or because they're hungry and they have to go work and get food or do something else. So trying to be mindful of all these things. This is a great program. They're really kind of helping us build up our advocacy base and be able to come in and tell those stories to the decision makers about why these things are so important. Let's see, any questions on POP on our program? And we're seeing this become a model for other organizations really across the nation. So this is something that's really, really cool. And this is just a few resources. I'm sure y'all will have access to the slides, but if you want to learn a little bit more about legacy and specifically the work that Public Affairs is doing, you can visit our website. And then the Texas Legislature Online is a really good resource. If there's bills, if you're in session and you hear about a bill, they're usually called HB or SB, so House bill or Senate bill, and then there's a number behind them. You can go and you can plug it in, and you can see what's going on with that bill. And it's really easy to use. They break it down super nice. It's not too wonky. It's a really good resource. Or if you want to do research on, what's gone on in the past, you can go in and you can use keywords and find things. And this is for anything, any type of legislature. So that legislation. So that's a really good resource as well. And then that's me. Please feel free to reach out to me if you have any questions or suggestions or anything that you want to chat more about as well. So that's what I have. Do y'all have any questions about anything? How about my online folks? Anybody have any questions? I don't know. Yes. Because right now it's illegal. Yeah, so it would involve a policy change. There has to be a complete. Good question. Yeah. I hear it on. Anybody have any questions? No? All right. Oh gosh, yes. Oh yeah. We've got columns all over the clinic. that's easy. Yes. You're welcome. Thank y'all for having me.